Welcome. In this lecture, we will talk about the health infrastructure and delivery system in India. So, we'll start from the grassroots level, that is village, moving on to district, state and center, and we'll see how different functionaries work at various levels. So the idea of this lecture would be to understand the PHCs, CHCs, the first referral units, and then the responsibilities at the center and state, the role of Ministry of Health and Family Welfare, and the organizational structure. So to understand, the basic idea is this whole health infrastructure talks about few important things. The first is organizing, the next is delivery, staffing, and regulation. And finally, the most important is the quality control of the health services across the country. So, under the aim of health infrastructure, our idea is to improve the status of health, improve the experience that an individual has for the care, reduce the economic burden on the ill, and provide a equitable platform where even the poorest of the poor can get adequate healthcare facilities at minimal expense. Now, when we understand the health infrastructure, it's not just the health infrastructure per se that we need to understand, but along with that, we also need to reconsider human values, the expectations of accountability, and the coordination among the resources that has to be met. So, to start with, from the village level, it's the village level where we have the Anganwadi workers, and then next to it, you have a sub center. On top of a sub center, there is a primary health care center known as PHC, then the community health care center CHC, and finally the first referral unit. Now, if the population in a plain area is somewhere around 5,000, it caters to a sub center. In the hilly area, the population norms are around 3,000. Primary healthcare centers are available for 4 to 6 sub-centers that are present, and this has an accountability of population up to 30,000. In the hilly areas, it's around 20,000. Community healthcare centers are relatively specialized with more equipments and healthcare facilities, basic operational devices that are present. And in the plain area, the population that it caters is nearly 1,20,000. In the hilly area, it is 80,000 population, right? So for each of these, the hilly area, tribal area, or difficult area, because of the dispersal of the population, the difficult scenarios, the difficult terrain, the population criteria has been kept lower as compared to the plain areas. Now, if we talk about after the community health centers, there are sub-divisional hospitals and then district hospitals. So across India, there are 810 district hospitals as per 2020 records, and the sub-district hospitals, the sub-divisional hospitals, there are nearly 1,193 such hospitals. The operational PHCs in India are around 10,000. 453. However, the total account is somewhere around 20,000, but of which only these many are functional, or I can say operational in nature, right? There is a shortfall, nearly 24% for the sub-centers, 29% for PHC, 38% for CHC, as per the rural statistics. And under the National Rural Health Mission, the financial support is provided to the states. The idea is to strengthen the healthcare facilities in the rural area and to upgrade the infrastructural facilities. So, with the focus areas, the state can have spendings up to 33%, and for other states, it's around 25% of the National Health Mission spendings on infrastructure that is provided. So, what is at the village level? It was called as the Village Health Guide, which started in 1977, which is now called as ASHA workers. Now, ASHA workers is a new name with National Health Rural Mission, catering to a population of nearly 1,000 people. And you have Anganwadi workers under the Integrated Child Development Scheme for every 400 to 800 population. We'll talk about Integrated Child Development Scheme, which is ICDS, later in this section. Also, initially it was the idea to train the local guys. This started under the rural health scheme, The training was imparted for 30 days period, but later on this was not a acceptable model, and this was not pursued further, right? So this integrated child development scheme, the ICDS, is important because through this the Anganwadi workers actually provide nutritional support, immunization, healthcare facilities, maternal and child health is checked, then nursing mothers, expecting mothers are taken care of, the preschooling, the non-formal schooling in the age group of 3 to 6 years age group is taken care of, and the nutrition for women in the age bracket of 15 to 45 years age group is taken into account. Now, the very first, the basic unit at the village level, we talk about the sub-center. Now, this is the most peripheral and this is the first contact point. So, what does it deal with? It deals with maternal and child health care, family planning, immunization, nutritional services, controlling any kind of communicable diseases if it spreads in the region, and keeping a record of birth and death, which is known as the vital statistics, right? So those are some of the functions of the subcenter. Now, what does a subcenter have? So every subcenter need to have at least one auxiliary nurse midwife, one female healthcare worker and one male healthcare worker, right? Also, there has to be one lady health supervisor, or who is known as one lady health visitor, who would supervise 6 sub centers. So every 6 sub centers would come under one lady health visitor, and she would be responsible for interpersonal communication with the auxiliary nurse midwives and would take care of the services reaching at the ground level. Now, these sub-centers work with 100% assistance being given by the Ministry of Health and Family Welfare in providing the assistance. There is various forms, for example, the salary of the auxiliary nurse midwife, the contingency grants, the lady health visitor, the salary of that, the rent for the sub-center around 3,000 is to be borne by the center. Then the wages of the male health worker would be taken care by the state government. Under the SWAP scheme, there are additional sub-centers which are being developed, and this actually provides the first point of contact. Next to the sub-center comes the primary healthcare center. As I said, 6 sub-centers are looked over by one PHC. So you have sub-center, sub-center, sub-center. So 6 such sub-centers being looked over by one PHC, right? The primary healthcare center. And this is the curative and the preventive health which is taken into account. And here there are beds in the hospital. Under sub-center we don't find beds, but here there are 4 to 6 beds which are present. However, the number of beds is still less. Under a CHC, this increases up to 30 beds. So, the PHC has relatively lesser number